afternoon to everyone. So today, like Darshan had said, our talk and discussions will be predominantly on basic sciences. So my topics for discussion are on permissive hypercapnia, hypoxic pulmonary vasoconstriction, management of ICD. That includes the relevant anatomy and management of a intercostal drain and the waterfall effect in relation to COPD management. So first topic we'll be discussing is on permissive hypercapnia. So the topics I'll be discussing under these are definition, the physiological effects of hypercapnia, the indications, contraindications, technique, cessation of permissive hypercapnia, and the adverse effects of permissive hypercapnia. So coming to the definition, permissive hypercapnia is a ventilation strategy that allows the unphysiologically high partial pressure of carbon dioxide to permit lung protective ventilation with low tidal volumes or low minute ventilation to be more precise. So the physiological effects in relation to hypercapnia can have its effect on various systems: cardiac, central nervous system, the diaphragm, the lung, that parenchymal and vascular, and miscellaneous that can be at the level of the intracellular level and other areas also. So first coming to the effects on the lung, I would have mentioned a plus sign over here and a minus sign over here. The plus sign means it has a positive effect, and the minus sign indicates it has a negative effect. So with relation to hypercapnic effects on the lung, it has a positive effect in relation to its anti-inflammatory effect. That is, it helps in suppression of neutrophil adherence to the endothelial cells in the lung, thereby helps in attenuation of ventilator-induced lung injury. But on the negative side, it causes impairment of the alveolar epithelial cell function, thereby reduced fluid absorption is there from the alveoli. Though this is more of theoretical, for my exam perspective, it is important to know about it. And regards to the effects on the circulation, that is pulmonary and systemic, one, on the positive side, it helps to augment the hypoxic pulmonary vasoconstriction, plus it helps in decreasing the intrapulmonary shunt, thereby helping in improvement of gas exchange. It helps in creating a rightward shift of the oxygen hemoglobin dissociation curve, thereby improving oxygen delivery to the tissues. Increase in PaCO2 levels helps to increase the sympathetic response, thereby helps to increase contractility and heart rate, thereby increasing cardiac output. And on the downside, it causes intense vasoconstriction of the pulmonary vessels. So increase in PVR can lead to increase in pulmonary afterload, RV afterload, thereby leading to impaired RV function in susceptible patients. With regards to effects on the CNS, most of them are negative effects. That is, it has a cerebral vasodilatory effect, thereby increasing cerebral blood flow, which leads to increase in cerebral blood volume, which can contribute to an increase in ICP. It can lead to agitation. It can lead to a comatose state, that is somnolence, which can become stupor and then go on to coma. And it also decreases the seizure threshold. So in susceptible cases, patients who already have a previous history of seizures, creating a hypercapnic environment can actually predispose to seizures. So with regards to the effects on the diaphragm, hypercapnia usually augments the myogenic tone of the diaphragm. That is, if it is less, PaCO2 is less than 80. But if it is more than 80, it starts to produce a inhibitory tone on the diaphragmatic muscles, which become more pronounced at effects more than 100 millimeters of mercury. And prolonged hypercapnia can itself lead to skeletal muscle atrophy because it leads to release of reactive oxygen species, which can lead to muscle injury and that can lead to atrophy. And miscellaneous effects, it can cause intracellular acidosis, thereby leading to inhibition of the actin-myosin linkages, leading to impaired muscle contractility. So that is a negative effect. And another effect that it causes is it can predispose to increased risk of infections due to a variable host response. So, like I said, it has an effect on the lung, it has an effect on the vessels, that's the systemic and pulmonary vessels. It has an effect on the cardiac muscle. It has an effect on the CNS, diaphragm, and miscellaneous effects. That is intracellular acidosis leading to impaired muscle contractility and increased risk of infections. So, where do we use permissive hypercapnia? So the main two documented indications are in patients with ARDS managed with low tidal volume strategy and patients ventilated for exacerbations of asthma or COPD who require low minute ventilation to reduce auto PEEP. And we also need to know what are the contraindications. So contraindications are patients with cerebral diseases, as we already know, because an increase in PaCO2 is ultimately going to lead to an increase in the intracerebral pressure, which is going to be more detrimental to the brain function. We don't want that. So in these subset of patients, we do not want an increase in PaCO2. And in patients with an already a pre-existing coronary artery disease with heart failure with reduced ejection fraction or presence of cardiac arrhythmias or patients with pulmonary hypertension with evident RV dysfunction, it's very much preferable to avoid hypercapnia because that itself can further worsen the underlying cardiac status. And even though I said that in the initial cardiac effects, cardiac output helps to increase the cardiac output by increasing the chronotropy and the inotropy, but it has a downside also. Thing is, in the pulmonary vessels, it helps to augment pulmonary vasoconstriction, but in the systemic vessels, it causes systemic vasodilation. So patients who present with a hypovolemic shock and if they have hypercapnia also, it is likely to exacerbate the shock in relation to hypovolemia because increase in PaCO2 causes a peripheral vasodilatation. So that also needs to be kept in mind. So how do you go about proceeding with permissive hypercapnia? So with regard to the ventilatory adjustment, permissive hypercapnia is a ventilator strategy in which hypercapnia is tolerated rather than being a ventilatory goal per se. So they say the clinician should incrementally decrease tidal volume or respiratory rate gradually and monitor the trend of pH and the PaCO2. So they say to go over the tidal volume change of 20 to 50 ml and a respiratory change of 1 to 2 breaths per minute and gradually assess the change in the pH and the PaCO2. The most important thing is the patient should be very much deeply sedated and if needed paralyzed also because hypercapnia can cause significant significant patient discomfort. So usually a target pH of more than 7.21 is well tolerated but should be individualized based on the patient's comorbidities and the tolerability. So usually we keep the target between 7.2 to 7.25. Usually we don't go less than that range of 7.2. And the most important thing to keep in mind is there is no role for sodium bicarbonate in the event of severe respiratory acidosis. It does not have any role, it is not beneficial, and it will not serve any purpose also. So, in patients who have developed permissive hypercapnia, which is with severe respiratory acidosis, that is less than 7.2, no role for sodium bicarbonate. So once you have managed the patient with the ARDS or with the ACOPD and you have the gas exchange has improved, that's when you are going to slowly come out of your permissive hypercapnia. So it is initiated only when the gas exchange improves and ventilatory adjustments are made slowly, that is over 24 hours, by incrementally increasing the tidal volume and the respiratory rate. Like I said, there is no hard and fast rule, but they say you go slowly. You slowly increase the rate by 1 to 2 breaths and increase the tidal volume by 25 to 50 ml. Although there are no data that is available to facilitate how quickly can be done, an approach that results in less reduction no greater than 10 mmHg per hour is the most appropriate measure of proceeding for cessation of permissive hypercapnia. So the adverse effects are, as you know, as I mentioned, the contraindications are mainly involving the CVS, CNS, and RS. So The adverse effects are related to these systems predominantly. So in CVS, it can cause arrhythmias, it can cause hypertension or hypotension. The mechanisms which I had explained previously, it can cause exacerbation of your right heart dysfunction and it can cause coronary steal in ischemic heart disease patients. Whereas in CNS, it can cause increase in cerebral blood flow, which can lead to increase in ICP, can lead to narcosis, it can cause a decrease in seizure threshold, and it can lead to a cerebral steal phenomenon in patients with ischemic strokes. And in respiratory system, it can worsen hypoxia, though it's a very rare scenario, but it is a possibility. So these are the things that we have discussed under permissive hypercapnia. So we discussed about the introduction, the effects on various systems, indications, contraindications, how do you initiate, how do you discontinue, and the adverse effects. So there are 7 areas we have covered. So usually if it is asked as a 5-mark question, within 2.5 pages, I think covering all these would be sufficient. So the next topic is about hypoxic pulmonary vasoconstriction. So under this, we'll be discussing about the introduction, physiology, the HPV mechanism, the physiological factors influencing it, and the clinical implications. So coming to the introduction, so hypoxic pulmonary vasoconstriction is a reflex contraction of the vascular smooth muscles in the pulmonary circulation in response to a low regional partial pressure of oxygen. So I'll just repeat it once more. It's a reflex contraction of the vascular smooth muscles in the pulmonary circulation in response to a low regional partial pressure of oxygen. So it is an important mechanism for matching regional perfusion and ventilation in the lung, occurring through the pulmonary arteries smooth muscle cells. That is also called as PASMC. So that actually has the main role in the mechanism of inducing HPV. So as you can see here there is normally ventilated lung units, and as blood flows, deoxygenated blood flows and passes through these ventilated units, it gets oxygenated and returns to the patient. But when there is an area which is not ventilated, a unit which is not ventilated, it induces a HPV response whereby these blood which is present in this area is diverted to the well-perfused, well-ventilated areas. So there is a good amount of gas exchange which occurs, thereby producing a good delivery of oxygen to the patient, despite a few lung units which have been non-contributory to the oxygenation. So coming to the physiology of it, systemic circulation causes vasodilatation in the presence of hypoxia. But in contrast, the pulmonary circulation vasoconstricts in response to hypoxia via the HPV, that is a hypoxic pulmonary vasoconstriction. So this is a protective physiological reflex that aims to divert blood away from the hypoxic areas of the lungs to areas with better ventilation and oxygenation, thus acting as an important process to maintain oxygenation. So coming to ventilation perfusion matching. So matching of alveolar ventilation and perfusion is a crucial determinant of gas exchange. This is something which all of us know. Because in an ideal lung where ventilation and perfusion is heterogeneous, that is in upright position, more perfusion and less ventilation at the base, and more ventilation and less perfusion at the apices, HPV reflex aims to improve matching of ventilation and perfusion, though its role in healthy lungs is minimal. So it will only cause minor changes because there's not going to be much significant influence on the oxygenation. But in contrast, the role of HPV is more significant in patients with COPD and interstitial lung diseases. So in these conditions, maintaining normal gas exchange is dependent on optimizing the VQ matching, which is influenced by HPV, which aids in oxygenation. So inappropriate delivery of supplemental oxygen in these scenarios, in addition to use of some drugs, can attenuate the HPV response and can lead to VQ mismatch ultimately leading to hypoxia, that is deterioration in the oxygenation. So coming to the HPV mechanism, so the main stimulus for HPV is the tissue partial pressure of oxygen in the region of the pulmonary arteriole. So it's a very big term to think about, but on the easier side, it is determined by two factors. One is the partial pressure of oxygen in the alveolus and the mixed venous oxygen. That is the P capital AO2 and the mixed venous oxygen, that is the P small v O2. So the site of action where this HPV occurs is, as I told, the PASMC, that is the pulmonary arterial smooth muscle cell. So the mechanism involves three steps. One is the biological oxygen sensing, that is the area where this hypoxia is being identified. Then the PASMC contraction and the modulation of activity. So these three things needs to be kept in mind. I'm just repeating it once more. One is the biological oxygen sensing, the PSMC contraction and modulation of activity. So the biological oxygen sensing occurs by because there is an inadequate oxygenation that occurs. That is, the gas exchange is inadequate in that lung unit to the vascular cell. There is going to be mitochondrial free radical production, that is reactive oxygen species production because of hypoxia in that lung unit which is devoid of oxygen. That will also be associated with the alteration of the cyclooxygenase and lipoxygenase systems. And eventually, because of hypoxia of the alveoli, or that is poor oxygen delivery of the alveoli, it will cause activation of the transcription enzymes via the hypoxia inducible factor. So these three are the most important factors that contribute to the biological oxygen sensing, which then triggers the PSMC contraction. So now this PSMC contraction, it is nothing complex. It is similar to what happens in a skeletal muscle contraction. So it acts by membrane depolarization after sodium ion influx, leading to an increase in cytosolic calcium ion concentrations. This causes an increase in the calcium ions available for binding to calmodulin, causing activation of the myosin light chain kinase, ultimately leading to contraction of the smooth muscle. So whatever we have learned in this skeletal muscle and smooth muscle contraction pathway, it is almost the same thing. So that is about the PSMC contraction. So once the biological oxygen sensing is being identified that there is a site of hypoxia which is present, then this PSMC contraction occurs, causing contraction of the smooth muscle. So these are the initial two steps. Then is the modulation of activity. So there can be two paths. One, there can be enhancement of activity, or one, there can be inhibition of activity. So enhancement of activity can be via endothelial one, which can cause potent vasoconstriction, or there can be inhibition of vasoconstriction via nitric oxide or prostacyclin, which can cause potent vasodilatation. So this is just a summary of what I just told, the three steps of it. So when there is a low alveolar oxygen which is being identified, the smooth muscle cells, I have a biochemical O2 sensing. So like I said, at the cellular level, reactive oxygen species will be increased. Then there will be alteration in your lipooxygenase and cyclooxygenase pathways. And there will also be release of your tissue inducible factor, that is hypoxia inducible factors. So that will cause activation of your PSMC, and modulation can be based on your other hormones. That can be endothelial one, or it can be because of other chemokines like nitric oxide or prostacyclins. So coming to the physiological factors influencing HPV, so there can be increase in HPV that can be associated because of hypercapnia, acidosis, hyperthermia, or initially at birth there can be an increase in the HPV, or HPV can be associated with iron deficiency and high altitudes. Similarly, decrease in HPV can be associated with alkalosis or hypothermia. So coming to the clinical implications, there are three important disease states which needs to be noted. One is pulmonary hypertension, ARDS, and high altitude pulmonary edema. So with regard to pulmonary hypertension, it can occur acutely or as an acute on chronic manifestation in critically ill patients. In many instances of acute pulmonary hypertension, it may go undiagnosed. And the most important thing is the choice of inotropes or vasopressors that are taken for management of cor pulmonale should be taken into consideration about its effects on the HPV also. With regard to ARDS, the impact of hypoxia, hypercapnia, lung volumes, PEEP, and atelectasis, all these can have activity on the HPV as a whole. And with regard to high altitude pulmonary edema, here HPV is activated in all lung regions due to hyperbaric oxygen, hypoxia. So that causes an increase in the pulmonary capillary pressure, leading to stress failure of the pulmonary capillaries, leading to extravascular fluid accumulation. So drugs that are associated are inhibition of HPV can be through the phosphodiesterase inhibitors like phosphodiesterase 3, like milrinone, or phosphodiesterase 5 inhibitors like sildenafil, inotropes like dobutamine, dopamine, adrenaline, acetazolamide, ACE inhibitors, prostacyclins, vasopressin, inhaled nitric oxide. So all these drugs can cause inhibition of HPV, and there can be activation of HPV via vasopressors like noradrenaline at doses more than 0.5 mg per kg per minute and phenylephrine. So these are the important takeaway points related to the drugs which can modulate your HPV. Just a second. I'll just be back in 1 minute. Sorry.
If there are any queries, you can actually post in between. The talks on basic sciences is focused only on paper one. Mostly you will get this here, or sometimes even in paper three for recent advances. So most of the topics that we have chosen is for your paper one or paper three topics. So few drugs are being considered just to give you an overview as to how to approach to them. And these are basic concepts in respiratory physiology, few other things that we have picked up where they can ask as a relevant anatomy or physiology. Navneet, I think so. We can mute the recording till Srihari is back.
Yeah, sure. So I hope everyone just had a note on the drugs that modulate HPV, that is inhibitory drugs and drugs that can activate it. So the next part we will go into is on the management of the intercostal drain and the relevant anatomy. So here I'll be covering the anatomy, the indications, management of a thoracostomy tube drain, and complications in relation to that. So coming to the introduction, thoracostomy tube placement belongs to one of the most performed procedures. So it's most commonly done as a life-saving scenario for tension pneumothorax, for enhanced recovery, that is post-surgical patients, for symptomatic relief in cases of malignancies. So despite many benefits of thoracostomy tube drainage, there is a potential for significant morbidity and mortality associated with use of these thoracostomy tubes. Hence, regular assessment and troubleshooting of complications is crucial for ensuring improved outcomes. So coming to the anatomy, this was asked last year as one of the questions, that is anatomy of, that's a triangle of safety, and they had asked about ICD management. So if you see, the way that we need to answer is, you can go with medial, lateral, and superior and inferior. So this will be the approach to that. So if you see, the anterior part of it is by the lateral edge of the pectoralis major muscle, and the posterior part of it, of the triangle, is by the lateral edge of the latissimus dorsi. The superior part of it is by the base of the axilla, and the inferior part of the triangle is by a line drawn from the fifth intercostal space. So the anterior part is by the lateral edge of the pex major. The posterior part is by the lateral edge of the pectoral latissimus dorsi. The superior part is by the base of the axilla, and the inferior part is by a line drawn from the fifth intercostal space. So it is mainly called triangle of safety as it avoids the damage to the chest wall muscles and the breast. And another important thing I just wanted to emphasize here is, thing is, for those who do ICD insertions on a regular basis, I don't think it would be a concern. But for for the first timers, it is always important to note, you need to place the ICD in the superior border, not the inferior border. For the simple reason, the neurovascular bundle that you can see over here is placed along the inferior border. So if you go along the inferior border and insert the ICD, there is a high chance you may injure the vessels, and that may further complicate things. So that is the important thing I just wanted to tell in relation to this slide. So coming to the indications, it can be for removal of air collection in the pleural spaces. That is, can be like a tension pneumothorax or a simple pneumothorax if patient is on mechanical ventilation. For removal of fluid collection in the pleural space, like hemothorax, malignant pleural effusion, if it is symptomatic, chylothorax, complicated parapneumonic effusion, or an empyema. Or use as a delivery conduit to introduce medications or fluid into the pleural space. That is internal warming via installation of warm saline. Pleurodesis with talc can be instilled to promote scarring of visceral and parietal pleura. Hypothermic intrathoracic chemotherapy in cases of malignant pleural mesothelioma and metastatic diseases. So in this, in every heading, at least two indications can be kept in mind when you're applying, when you're writing it in the exam. So coming to the chest drain system, we have a 1 bottle, 2 bottle, and a 3 bottle system. So the 1 bottle system, as you can see here, has two main functionalities. One, it acts as, there is a water seal and there is a drainage bottle. Both of these are in the same compartment. Whereas in the 2 bottle system, 1 bottle is dedicated for the water seal and the drainage, as you can see, similar to a 1 bottle system. And the second bottle is specifically dedicated for a suction control. In a 3 bottle system, there is, each bottle is dedicated to a separate function. That is, one is for drainage, one is for water seal, and one is for suction control. That is three specific functions. So just for memory purposes, in a 1 bottle system, it is seal plus drainage. In a 2 bottle, there is seal plus drainage for one and suction for the other. And in a 3 bottle system, we have one for drainage, one for seal, and one for suction. So thoracostomy tubes placed in hospital patients require daily assessment to determine the presence of air leak, provide ongoing adjustments of suction level, and monitor for malfunction, which may include obstruction, malposition, or disconnections. So this is very important, needs to be kept in mind when you are managing a thoracostomy tube. So management of a thoracostomy tube drain post in placement has 5 important areas that needs to be covered. That is, one is precautions during initial drainage, monitoring of the patient, assessment of the thoracostomy drain, chest physio, and patient transport. So coming to the precautions during initial drainage, the amount of thoracostomy drainage should be assessed on a regular basis, which has to be hourly in the setting of trauma. So what they say is, with traumatic hemothorax in general, Immediate drainage of 20 ml per kg or accumulation of more than 3 ml per kg per hour of blood is an indication for thoracotomy to identify and manage a thoracic vascular injury. In cases of massive pleural effusion, the fluid drainage should be very slow. Not more than 1 liter should be drained in the first go itself. So, if at all almost 750 ml has been drained, it needs to be clamped and thereafter it has to be drained at intervals of 1 to 2 hours, about 300 ml of a time thereafter, with a tube clamped in between. This is very, very important because if it is not done properly and you in one go you allow a large volume of fluid to be drained out, that can lead to re-expansion pulmonary edema and further worsen oxygenation, necessitating to the extent of intubation and mechanical ventilation. In the rare case of a large effusion with active air leak, it is a very controversial area because in one side the tube cannot be clamped. But if you keep the tube open, the leak component is also not going to be addressed. So usually this scenario will be asked in Viva in the practicals. So I just thought I'll give it here for completion's sake. So if at all they ask a scenario where there is a large effusion and an air leak also, what do we do? The drainage tube can be draped from the insertion site to a level above the patient's head and then back to the drainage system, which is ideally situated on the floor. So this creates a fluid trap that allows the air to be safely escaped but slows the drainage of fluid. I'll just repeat it once more. In cases of a large effusion plus an active air leak, the drainage of the tube can be draped from the insertion site to a level above the patient's head and then back to the drainage system, which is ideally situated on the floor. The main purpose of this is to create a fluid trap that allows the air to safely escape but slows the drainage of fluid. So if the collection bottle gets filled with drained blood or fluid, it should be emptied and after clamping the tube, and it is to be done in a completely sterile manner. The drainage system must be kept upright for the water seal chamber to function correctly. That is also a very important thing to be noted. And the chest drainage system must be lower than the chest to facilitate drainage and prevent backflow. So the next part of it is about the monitoring. So monitoring of the patient, the basic is the vital signs. That is the heart rate, BP, saturation, respiratory rate, and the GCS. Then the pain assessment. Because if it is a pigtail catheter, the pain is relatively less because it has very less impingement on the surrounding nerve structures. But if it is a ICD, there is more amount of muscle tissue that is involved. That is going to cause more pain and discomfort, and that is going to impede on your physiotherapy and rehabilitation. So adequate pain management needs to be addressed. And the site of insertion and the dressing needs to be assessed on a regular basis. Especially if the ICDs have been kept for a long time, it has to be looked as a potential source of infection. So the site needs to be looked upon for presence of pus or and during the initial phases, there should be always assessment for presence of any soakage of blood which is present in the dressing. So that should be a concerning sign. And respiratory parameters, that inspiration of bilateral chest movement should be seen, and auscultation of the chest to assess the intensity of the breath sounds. That is like pre-insertion and post-insertion. If there is any improvement in auscultation, that will be a good aid to identify the success of your intercostal drain insertion. But in our current era, focus plays a better role. Chest X-ray is done to assess the exact position of the chest drain and to evaluate the status of the underlying chest expansion. And another important thing is to assess for the presence of subcutaneous emphysema. Sometimes one of the holes of the ICD tube might be little dislodged and be placed in the subcutaneous plane. So that itself, for a period of time, if it is not looked into adequately, can lead to the increased incidence of subcutaneous emphysema, which may further increase morbidity. So assessment post-insertion should be at least every 15 minutes for the first hour immediately following chest tube insertion. And any alteration in the patient's hemodynamics or respiratory mechanics should be monitored for appropriate management. So the next part is about assessment of the thoracostomy tube drain. So the first thing is about monitoring for tidling. So what is tidling? When the fluid along the dependent portion of the tubing is seen to move back and forth with the respiration, it is a sign that the chest tube is patent and it is affected by the negative pressure created by the diaphragm. So absence of tidling may indicate there is a tube occlusion which needs to be looked into. The second thing is assessment of integrity of the drainage system, that is the amount and character of drainage. The important thing to note is if there is any significant changes compared to the initial findings. Assess if the tube is kinked or bent, which may interfere with the drainage. Check the water levels in the water seal chamber. If it is inadequate, there can be excessive suction pressure that can occur on the delicate pleura. And make sure the chest tubes are not clamped. That is a very, very important thing to be looked into. Then the one of the most important things for assessment is assessment of air leaks. So presence of air leaks should be assessed to determine whether the tube can be removed. So most intrathoracic air leaks will usually seal spontaneously and resolution can be tracked by witnessing decreased bubbling in the devices over days. So bubbling within the chamber can also be related to a air leak anywhere within the circuit. Now, our usual mentality is if there is air leak in the system, it is usually associated to a bronchopleural fistula. That is not the case. You need to go in a stepwise approach. You need to isolate where the exact source of the leak is because it can be downstream also. So what they say is you begin evaluation at the chest tube insertion site to evaluate if there is an atmospheric air tracking into the thoracic space via the chest tube insertion site, that is the incision site or the tube position. Then clamp the tube near the patient and briefly to assess if the leak is downstream, that is from outside of the patient. So if it is so, then you need to replace the unit. And once all these are ruled out, then you look for any intrathoracic pathology, that is like a bronchopleural fistula. So qualitative air leaks can be classified as follows with increasing severity. So if it is only present with forced expiration, that is like with Valsava maneuver or coughing, it is just a mild leak. If it is present just during the expiratory phase, it could be an alveolar pleural fistula, which is also under a mild scenario. Whereas if it is present also during the inspiratory, uh, more during expiration than inspiration, then it could be an alveolar pleural fistula or a bronchopleural fistula. Whereas if it is continuous, that is, there is continuous bubbling which is occurring during both inspiration and expiration equally, then it is a true bronchopleural fistula which needs to be taken seriously and for which a cardiothoracic surgeon's consultation would also be needed. So the level of suction. So the initial level of suction used in the clinical setting is -10 to -30 centimeters of water. When the thoracostomy tube or catheter is placed for fluid drainage, -20 centimeter of water is a reasonable place to start. And the level of suction should be increased as indicated with the goal of achieving full lung expansion as determined by the chest radiograph. So many a times we just have connected the patient's ICD to a negative pressure suction and just leave it for days without any manipulations, but that is not the right practice. The ideal thing is to assess the clinical scenario and assess the radiological clearance of fluid of air, and then accordingly take a call whether to continue on suction if it is needed further or not. So for a collapsed lung due to pneumothorax or copious pleural effusions, large differential pressure gradients should be avoided during lung re-expansion to prevent re-expansion pulmonary edema. And if suction is not ordered, ensure that the port is left to open. So the next part is related to the chest physiotherapy. Under this, the patient should be encouraged to ambulate as soon as possible. So deep breathing and breath holding exercises should be initiated as soon as possible after chest tube insertion. So this facilitates effective lung expansion and drainage of fluid. And the last part of it is patient transport. So during transportation, The chest tube bottle and bag should be always kept below the level of the chest level. It is important not to clamp the chest tube as continuous drainage is the safest approach. In cases where there is an air leak from a lung surface, clamping the tube will lead to accumulation of air in the pleural cavity, causing lung collapse and sometimes increasing the risk of developing a tension pneumothorax. So coming to complications, you can classify it as organ-specific complications whereby any of the system surrounding the lung can be involved. That is esophageal injury, gastric injury, bowel injury, hepatic injury, splenic injury, diaphragmatic injury, lung injury, which can be associated with perforation, infarction, or bronchopleural fistula. There can be cardiac or major vessel injury, intercostal arterial hemorrhage, especially if you're going through the inferior border, and chylothorax if the left lung is being sorry if there is a left-sided pleural disease and an ICDB has been inserted for the same. Then you can have technical complications, whereby there can be a non-functioning tube because of a kink clot or a dysfunctional closed system. There can be a subcutaneous placement, especially in very obese patients, whereby you may not be able to identify the plane direct correctly. There can be tube dislodgement or removal, or there can be physiological complications like re-expansion pulmonary edema, and in very rare circumstances, there can be vagus nerve irritation. And infectious complications, that is at the insertion site. In the most severe scenarios, it can cause necrotizing fasciitis, and also empyema can be another also associated complication in relation to thoracostomy drains being kept for a very long period of time. We did have a lot of cases in relation to empyema during the COVID era, because during the second wave, there were a lot of patients who had an impaired mechanics. So invariably, many patients developed pneumothorax and had an ICD in situ, and we were not able to wean off ventilation because of their underlying lung status. So the ICD was inside for a very long period of time, and that itself led to new infections. And one among them was empyema, which was actually very difficult to treat. So infection complications should always be kept at the back of the mind. So the last part of it is in relation to removal of thoracostomy tubes. So to minimize the risk of infectious complications, the ICD tube should be removed as soon as it is safe to do so. So the criteria in cases of pneumothorax, number one, the lung should be expanded fully. There should not be any visible leak present, and air does not accumulate when suction is removed. If the patient is on mechanical ventilation, the patient should be on pressure support mode, preferably prior to ICD removal. Whereas in cases of a pleural effusion, the first criteria is the lung is adequately expanded, the drain output is less than 100 ml per day, there is no fresh or altered blood or pus draining from the chest tube. So with regard to the removal technique, before removing the chest tube, the nurse assistant should be ready with the following: a dressing set with sterile gauze pieces and artery forceps, sterile water impermeable adhesive wound dressing, and or a adhesive tight dressing. So at the peak of deep inspiration, the chest tube should be pulled out gently. One person pulls out the tube, the other person should be ready to tighten the purse string sutures to prevent any air entering the chest, especially with post-surgical drains. A water impermeable occlusive dressing is applied at the site of insertion, which is then removed after 48 hours. So post-removal, it is important to assess for respiratory distress, and a chest X-ray should be done to look for pneumothorax or any other abnormalities. So these are the first three topics that I discussed. One is permissive hypercapnia, HPV, and ICD management with the relevant anatomy. So the last talk for me is about the waterfall effect in relation to COPD. It is also called the Pride's waterfall analogy. So I'll be discussing it under two headings. One is the introduction and the topic proper. So coming to the introduction, normally the lung at end expiration generally approaches a relaxation volume of the respiratory system. That is, The lung volume determined by the static balances between the opposing elastic forces of the lung and the chest wall. That is, the pleural pressures play an important role in maintaining the lung patency from getting collapsed. But in patients with an airflow limitation, that is, in patients with an acute exacerbation of a COPD or an asthma, the end expiratory volume may no longer be determined by an equilibrium between the static forces, that is, the elastic recoil forces between the lung and the chest wall. Instead, the end expiratory lung volume may exceed the predicted FRC of the lung. Because the rate of lung emptying is slowed, expiration is interrupted by the next inspiratory effort before the patient has exhaled to the static relaxation volume. So this is termed as dynamic hyperinflation. So the main reason why I had explained about this is to understand the waterfall effect, we need to know a small basic understanding of dynamic hyperinflation. Only if we do understand about this, we'll be able to apply the concepts in relation to that. So factors that influence dynamic hyperinflation are: one is increase in tidal volume, prolonged time constant. So time constant is nothing but a product of resistance and compliance. So a prolonged time constant for emptying the respiratory system and a shortened expiratory time. So all these factors will lead to dynamic hyperinflation. So at normal end expiration, the static recoil pressures of the respiratory system is usually zero, whereas a positive value is observed in patients with dynamic hyperinflation. This positive recoil pressure is called as auto PEEP or intrinsic PEEP. And the problem with this is it is associated with increased work of breathing. So the increased work of breathing from auto PEEP can be decreased by various therapeutic measures like bronchodilator therapy, use of a larger size endotracheal tube, decreasing the minute ventilation by controlling fever or pain, minimizing the ratio of inspiratory to expiratory time, and which also includes increasing the inspiratory flow rate. And one of the other important factors is application of external PEEP. So patient already has an auto PEEP. So isn't application of an external PEEP to an already occurring intrinsic PEEP supposed to be harmful? So this was a question that had come up way back in the 1980s. So that was when they had done a study and then they had postulated this waterfall analogy, whereby they had shown that use of this external PEEP to an extent is supposed to be beneficial in these subset of patients. Specifically, this airflow limitation in relation with COPD and asthma, application of external PEEP helps to reduce the intrinsic PEEP effect to an extent. So, coming to the waterfall analogy, here the important thing, if at all it is being asked, first diagram that we need to put is this diagram. So here you can see that there is a alveolus, that is the distal alveoli, which is the upstream segment, and the proximal airway, which is the downstream segment. So because of a bronchoconstriction, there is a airflow limitation whereby there is a narrowing of your airways. This area will be the waterfall. And this pressure, which causes this collapsibility of the airway, is called the critical pressure. So it is nothing but the transmural pressure of the airway where flow is limited during forced expiration. So this is the site of the waterfall. So I'll just explain this diagram once again. With regard to the waterfall analogy, the distal alveoli is the upstream segment and the proximal airway is the distal or the downstream segment. The area where the alveoli get collapsed is the area of flow limitation, and the pressure which causes this flow limitation is called the critical pressure, which is the transmural pressure of the airway where flow is limited during forced expiration. So the important take home is where the upstream segment starts and where the downstream segment starts. The upstream segment starts at the level of the alveoli and the downstream segment starts at the proximal airway. So if this initial diagram is clear, then we can go into the second part of it. So because of the development of an autopeep, the alveolar pressure will be higher, that will be positive. So because of this flow limitation, it will cause an increase in pressure needed to push the gases from the distal, that is from the upstream segment to the downstream segment. So that can be compared to a hydrostatic pressure in the stream. So as you can see here, this area is like the distal alveoli and this area is the proximal alveoli. So because of the intrinsic peep that is present, the pressure is high and the height of the waterfall, that is the stream, is also high because of the intrinsic pressure. So as it passes through the narrowed airway, that is the flow limited airway, it causes an increase in hydrostatic pressure. So once that it passes through that flow limitation and then comes to the proximal airway, then this waterfall effect is created. So this is the second part of it. So as you can see, this is the flow limitation, as I said, that in relation to the critical pressure at the area where there is a narrowing of the bronchioles. And this is in relation to the waterfall picture that is seen over here. So I hope this part is clear. So the higher area that is seen over here is the distal alveoli, where the intrinsic peep is predominantly present. And this area which is present over here is the proximal airway, where once the uh, gases have passed through the flow limitation, it has entered into the low pressure area. So the first analogy is you have an intrinsic peep of 10, but the extrinsic peep is 0. That is similar to the previous diagram that we had seen. When no extrinsic peep is applied, there is greater hydrostatic pressure at the waterfall, meaning more energy is required for the flow of gases from the distal to the proximal airways, with flow limitation being present. I hope this is clear. Now, this is the second analogy. That is, we have tried to increase the external peep to 10 with an intrinsic peep of 10 already being present. So what they say is, now suppose the tide comes in, that is the external peep is applied, raising the height of the stream below the waterfall to almost the level of the waterfall. This helps to reduce the flow limitation to an extent, allowing the exit of gases from the alveoli to the proximal airway to be easier. So when this airflow limitation was so significant, it was unable to release the gases that are present in the alveoli towards the proximal airway. But when you create a external peep, that helps to push up the tide, that helps to push the tide up, thereby somewhat neutralizing the pressures, allowing the exchange of gases from the distal to the proximal airways. So this is the area where the benefit of external PEEP was found. But sometimes when you go with an overzealous management of external PEEP, when there is already an intrinsic PEEP of 10 and you go with an external PEEP of 12 or more than that, the upstream pressure is increased and that hyperinflation is exacerbated. What it means to say is that you are actually increasing the risk of barotrauma. So they say for auto peep if 10 that is present, the extrinsic peep should be almost at the same level. Now, in our modern day ventilators, we go with an expiratory pause of around 10 seconds. We assess the PEEP and then accordingly adjust it to the two-thirds of it. Now, why do we go with two-thirds is there is a reason. Thing is, there is no accurate measurement for exactly identifying how much is the auto peep. So if the patient's showing and if you have found, if you have calculated the auto peep to be 10 and we go directly place the external peep at 10, there is a potential risk of a barotrauma that is likely to occur. So to avoid that risk, we go with two-thirds. That is, to be more precise, they say to go with 60 to 70% of your external peep. So that is the main rationale for going with your external peep of 60 to 70% to counteract the auto peep. So I hope this concept is clear. If you have any queries in relation to this, let me know. I will again try to explain it in a easier way. Thank you.